Hi, so if anyone happens to watch this video, this is not a treatment advice or anything based on official guidelines. I'm just trying to revise out loud, think out loud, and for people who are preparing for QE1 or step 2, watch this video. This is not a comprehensive details of any condition. I'm just trying to see the key points from what I studied, and I'm just trying to pick up things to solve the question faster. And I did immunology for the past couple of days, and I'm going to revise them out loud now, hoping that it will help me revise later as well. So firstly, with immunology, I'll go with the 5 common things which I kept seeing again and again. So those are these 5 things: X-linked gamma globulinemia, common variable immunodeficiency, severe common immunodeficiency, DiGeorge syndrome, Wiskott-Aldrich syndrome, and ataxia-telangiectasia. Out of these 5, the most common were X-linked gamma globulinemia, common variable immunodeficiency, and SCID, severe common immunodeficiency. With that, the common granulomatous disease and leukocyte adhesion disease as well. And these CGD and leukocyte adhesion disease has most of the things. Has something in common, most of the key features. So in the questions I need to look out for them. So first I will go with chronic granulomatous disease. It's mostly caused by catalase positive organisms, and the most common catalase positive organisms are Staphylococcus aureus, Burkholderia, Pseudomonas cepacia, Serratia marcescens, Nocardia, and Aspergillus. And with chronic granulomatous disease and severe combined immunodeficiency disease and X-gamma globulinemia, if the question has the infants mostly start thinking with these three things: CGD, common granulomatous disease, severe combined immunodeficiency, and leukocyte adhesion disease. First, I'll start with the CGD. Yeah, as I said, it's catalase positive organism. I'll be going forward and backward because my mind keeps linking things. As I said, it's mostly based on catalase positive. It's recurrent catalase positive infection, which common are Staphylococcus aureus, Burkholderia, Pseudomonas cepacia, Serratia marcescens, Nocardia, Aspergillus. And mostly they don't have any problem with the viruses. And how this CGD, the pathophysiology is that due to the mutation of NADPH oxidase, which causes impaired respiratory burst, and that causes decreased reactive oxidase or O2 species or anions. And what's similar with leukocyte adhesion disease is that the leukocyte adhesion disease, there is defect in CD18 containing integrins, which causes low bradykinin, which stops the leukocytes from going from the blood vessels to the infection site. And I think if I go only by one disease, it will be better. So I'll just stick with CGD, and it's X-linked recessive. So if it's a boy and a kid, just think about CGD first. Other things, if they ask for the pathophysiology or what you're gonna check, we are gonna check for this respiratory burst, reactive superoxide. And the tests for this, the most common one is the flow cytometry, DHT. DHT is dihydro, I don't know how to pronounce this, dihydrohydamine test. And the other tests which are less commonly done is NBT, nitroblue tetrazoline. And while doing this test, if we see fluorescence green, then it's not CGD. If we don't see it, it is CGD. And also, if we do fine needle biopsy, it will show inflammatory reaction with granuloma formation. And the investigation of choice I just told, and also the confirmatory test for this is phenotype, severe phenotype. Confirmatory test for this is gene testing, and the severe phenotypes are treated with interferon gamma therapy. And the most common, I mean not the most common, these people will most commonly need prophylaxis with trimethoprim, sulfamethoxazole, and itraconazole. And yeah, so the most common presentation is recurrent cutaneous and pulmonary infection like lumps and perianal abscession, which are something I found in the most of the questions. And less common infections are suppurative adenitis and osteomyelitis. I don't know if I'll remember this because I've written it very in small letters. Very importantly, the CGD people have normal T cells. The T cells are normal in DiGeorge syndrome as well. And this DiGeorge syndrome, yeah, where did I write the DiGeorge syndrome? I written it somewhere. Yeah, this DiGeorge syndrome is also found in kids. They have dysmorphia, facial features, palatal defects, cardiac abnormalities, and important thing is deficiency of calcium metabolites. They have developmental delays and lymphopenia. The developmental delays and lymphopenia are something I'll forget. The cardiac abnormalities and the calcium metabolites deficiency will something I'll remember. And dysmorphic facial features and fatal defects are something I need to remember strongly as well. And the treatment is cultured thymic transplant. The DiGeorge syndrome is due to 22q11.2 microdeletion syndrome. And okay, one another thing is that in similar with CGD, Chediak-Higashi syndrome also has defect in intracellular killing. Chediak-Higashi syndrome. And yeah, that's all about okay. One another thing is that CGD has interferon gamma deficiency, which results in disseminated mycobacteria diseases because of the intracellular killing of macrophageal activated by this. So interferon gamma defect also causes disseminated mycobacteria disease with catalase positive organisms maybe. And okay, firstly I'll go with the kids thing. The second one would be severe combined immunodeficiency. So in CGD, we have recurrent cutaneous and pulmonary infection. So if it's a cutaneous and pulmonary infection, we are going to think CGD, chronic granulomatous disease, and leukocyte adhesion disease. But in severe combined immunodeficiency, there are recurrent severe infection of chronic diarrhea, GI. I need to check if this has sinopulmonary infection as well, because the recurrent sinopulmonary infection is also a very common presentation, but I think that's an X-gamma globulinemia. I don't know, I have to make sure of that. And the etiology of severe combined immunodeficiency is gene defect, which causes failure of T cell development, and thus the poor differentiation of B cells and B cell dysfunction. So both T cells and B cells in severe immunocombined deficiency, and only B cells in X-linked A-gamma globulinemia, right? They have normal T cells. And in DiGeorge syndrome, why did I write it at last? Yeah, in DGH syndrome also we have low T cells and SCID. So what's common with chronic granulomatous disease and oh no, I'm confusing it. Maybe, yeah, here T cells are normal, but what's common with DGH syndrome? Maybe there was nothing common with CGD and DGH syndrome. I don't know why I confused. So the severe immunocombined deficiency and DGH syndrome has the severe combined immunodeficiency, and DGH has normal T cell, the poor T cells. Yeah, the poor T cells. And severe combined immunodeficiency has this recurrent infections. I have to make sure if it's sinopulmonary and gastric, but the most is gastric. And one important thing is failure to thrive. Failure to thrive. If it is a kid and they failure to thrive, it's severe combined immunodeficiency. However, common variable immunodeficiency also has failure to thrive, but common variable immunodeficiency is in much older people, 20 to 40. That's the presentation, or that's the age of presentation with common variable immunodeficiency. And this is X-linked recessive and autosomal recessive, so mostly in boys for the X-linked recessive. And the treatment here is stem cell transplant. This is something I need to remember. Severe combined immunodeficiency needs stem cell transplant, not just immunoglobulin therapy or anything like that. As a short-term treatment, we will give the IVIGs, also broad spectrum antibiotics, while they are awaiting transplant. This kid, severe combined immunodeficiency people, apart from being failure to thrive, this is very fatal as well. And the lab will show hypogammaglobulinemia, decreased T cells, CD4, CD8. And yeah, one another thing, the gene defect which caused this failure of T cell development is due to adenosine deaminase deficiency. And live attenuated vaccines are very much contradicted in severe combined immunodeficiency. Live attenuated vaccines are very much contraindicated in severe combined immunodeficiency. Yeah, that's all about severe combined deficiency I studied in the past couple of days. And the third one is X-linked A gamma globulinemia, which is also called Bruton A gamma globulinemia. And yeah, these are, if you find in the question, if the pathogen they find is an encapsulated bacteria like Streptococcus pneumoniae and Haemophilus influenzae. Streptococcus pneumoniae and Haemophilus influenzae, then just think X-linked gamma globulinemia. The connection here is that X-linked A gamma globulinemia has the infections by encapsulated bacteria Streptococcus pneumoniae and Haemophilus influenzae. And one another thing which has common infection by this encapsulated organisms is combined immunodeficiency, what do you call it? Common variable immunodeficiency. So how I'm gonna remember this is X-linked. The X is like encapsulated, and while with COVID we were all closed, so common with the CVID, COVID, and this X-linked X, these two are by encapsulated bacteria, especially these two guys, Streptococcus pneumoniae and Haemophilus influenzae. And the etiology is decreased B cell concentration and decreased IG levels. So why this decreased B cell concentration is, not just decreased, that it can be absent too. This is due to the defect in pre-bone cell maturation in bone marrow. Pre-bone cell maturation in bone marrow. This is the cause of the B cell defect in X-linked A gamma globulinemia. And let me check. As it is as it is a genetic defect, The BTK gene mutation is what causes the X-linked gamma globulinemia. This BTK gene mutation will cause defective Bruton tyrosine kinase. We call it Bruton gamma globulinemia. So the gene BTK gene mutation. And oh, one another important thing is if they have abscess, they are not hot, they are cold. So if the question has that the cold abscess kind of description, then think of X-linked gamma globulinemia. And the pathophysiology is that impaired neutrophils and B cell maturation, impaired neutrophil chemotaxis and impaired B cell maturation. The clinical features are sinopulmonary and gastrointestinal. So yeah, I was confused if this severe combined immunodeficiency has sinopulmonary infection. I need to go back and check if that has that as well. However, in X-linked gamma globulinemia, there are going to be respiratory and GI infection involvement. And some other clinical presentation which are less common is rheumatoid arthritis, thyroid disease, bronchiectasis, fibrosis, rheumatoid arthritis, thyroid disease, bronchiectasis, and fibrosis. The investigation of choice here is flow cytometry. Where we do flow cytometry in another place is with chronic granulomatous disease. And this flow cytometry might show decreased CD19 plus cells and normal T cells. The treatment here is immunoglobulin replacement therapy, prophylactic antibiotics. There is one another condition which also requires IVIG, which was CGD, although that was not yeah, that's only for severe cases. There was one another condition which had IVIG transfusion is common variable immunodeficiency. So with X-gamma globulinemia and common variable immunodeficiency, which is with adults in 20 to 40 years, we do IVIG as well. And X-gamma globulinemia, what are other things here? Yeah, they of course need prophylactic antibiotics. One another thing is this X-linked gamma globulinemia kids have all of their immunoglobulins low, and this usually starts after 3 months. So the till 3 months, the kids have the infants have the IgG from the mother, and once it starts to wane off, they start having these symptoms, as of course that X-linked ones. So it's typically in boys, and if the question has family history too, then think of X-linked gamma globulinemia. And the third one which I wanted to do was, I forgot. No, I think I did the 3. So I did CGD, chronic granulomatous disease, and severe combined immunodeficiency, and X-linked A gamma globulinemia, Bruton A gamma globulinemia. And the connection I wanted to make here is that I told you that fatal in early childhood was severe combined immunodeficiency. So one another thing which is very lethal is leukocyte adhesion disease. The connection I made was with severe combined chronic granulomatous disease. So this leukocyte adhesion deficiency, classic lab findings are leukocytosis and neutrophilia. If you see leukocytosis and neutrophilia and everything else is kind of normal, then think about leukocyte adhesion deficiency. This most commonly presents in mucosal and skin. So like cellulitis, periodontitis, leukocyte, because the leukocytes cannot travel to the site of infection, so they have it there. And most importantly, the skin and mucosal lesions does not have any pus formation. There is necrosis and ulceration, but there is no pus formation. And the other important thing to note here is umbilical cord separation. I don't know if you call it umbilical. So there is delayed umbilical cord separation in leukocyte adhesion disease. One another thing I studied today regarding umbilical cord is that in Wistak-Atrick syndrome, they have thrombocytopenia. So with you can see bleeding from umbilical site and bleeding after circumcision. This is due to thrombocytopenia, and this is an X-linked disorder as well. And in here you have both B cells and T cells low. The other place where we had B cells and T cells low was severe combined immunodeficiency, right? And I don't know why there is low B cells and low T cells, but there would be elevated IgA and IgE and low to normal IgG and IgM in Wiskat-Atrick syndrome. So I was at leukocyte adhesion disease. There is delayed umbilical cord separation, and impaired wound healing. Yeah, of course, because of the inability for the leukocytes to travel there. So what happens with this etiology is that the defect in CD18 contains integrin. Integrins are the important thing which requires neutrophil migration. So CD18 defect causes integrins unable to transport the neutrophils to the site of infection. And most common pathogens here are Staphylococcus aureus and gram-negative organisms. And on top of the skin and mucosal presentation, they also have GI and respiratory, but mostly if there is skin and mucosal, think leukocyte adhesion disease. This is a life-threatening thing too, as I told earlier, and this is a prolonged infection. And yeah, that's about leukocyte adhesion deficiency disease. So now these are the kids thing, and now I'll go to common variable immunodeficiency, which has a name similar to severe immunocombined deficiency. So this is a primary humoral immunodeficiency, not cellular. It presents in adolescence around puberty. If the question is about a 12-year boy or a 12-year boy or a girl or 20 to 40 years, we can think of common variable immunodeficiencies with recurrent sinopulmonary infection. As I told earlier, these are by encapsulated bacteria, Haemophilus influenzae and Streptococcus pneumoniae. The other thing with encapsulated bacteria I studied today was X-linked gamma globulinemia. And the common infections are chronic pulmonary disease, asthma bronchiectasis, and recurrent diarrhea caused by Salmonella, Campylobacter, or Giardia. And why chronic pulmonary disease in common variable immunodeficiency is due to low IgA. So there is no opsonization. Poor response to vaccines. These people have poor response to vaccines as well. Something I studied about vaccine, or I told about vaccines earlier, is that there are no live attenuated vaccines to be given to severe combined immunodeficiency. So these two are both common in severe combined immunodeficiency. I mean, we don't give live attenuated vaccines to severe combined immunodeficiency, and poor response to vaccine in common variable deficiency. These people also have failure to thrive. So even though they are adults, we can find low weight and other things. The immunoglobulin profile here will be low IgG, low IgA, and sometimes low IgM. The treatment here, as I mentioned earlier, is immunoglobulin infusion. And even with the treatment, there is risk of autoimmune disease and malignancies. Investigation of choice here would be quantitative assessment of IgG, all the immunoglobulins. Sometimes there were options with the pathophysiology or what you would check in this case. So you think which disease, and then we come at the investigation of choice or the pathophysiology. And common immunovariable deficiency, people has cellular immunity good, so no prophylaxis of antibiotics or antivirals are required. So probably I think that's how they survive till they don't have any problem till they are adults. Okay, and they also have failure to thrive, unwieldy immunoglobulins. That's all about common variable immunodeficiency, primary humoral immunodeficiency. So now just I'll give a tick for all those things I have already revised. So CGD done, common variable immunodeficiency done, severe combined immunodeficiency done, X-linked agammaglobulinemia done, leukocyte adhesion deficiency was also done. Yeah, the other important condition which I found a lot of questions were from hereditary angioedema. This also has something in common with leukocyte adhesion disease because of the skin and mucosal infections. This is an autosomal dominant disease, and the de novo mutation is the mutation. Key features here you find between allergy and hereditary angioedema is that there are no pruritus or urticaria. So if the patient presents with only angioedema, then it is due to you can guess hereditary angioedema. But what I was thinking is, oh yeah, so here we have C1 inhibitor deficiency, and there are less bradykinin. So bradykinin is a vasodilator. So without the vasodilator, inflammatory mediator. So because of that, there is fluid retention in the skin. So what I was thinking about is the integrins in leukocyte adhesion disease. Was it integrins? Leukocyte, yeah, leukocyte adhesion disease, which was by CD18. Here CD18 cells, here it is C1 inhibitor and bradykinin. The features are cutaneous swelling. Very, very interestingly, they also have colicky abdominal pain. I think I have to go back and study why they have colicky abdominal pain on top of this cutaneous swelling and presentation. So they have colicky abdominal pain, vomiting, and diarrhea. The fluid into skin, you can mostly see in edema of face, limbs, genitalia, bowel, and larynx. And of course, with the edema of the skin and mucosa, you're going to find laryngospasm and airway obstruction. And the fact there is always or mostly family history positive. The one other condition where we studied today where we will have family history positive is agammaglobulinemia. The treatment for acute presentation is C1 inhibitor concentrate, bradykinin antagonists like icatibant, because I want to remember this, bradykinin antagonist, icatibant, and kallikrein inhibitor. The example is eclanatide. Icatibant and eclanatide. Icatibant is bradykinin antagonist, and eclanatide is kallikrein inhibitor. So very, very interestingly, this hereditary angioma can be just caused by stress or trauma, and they resolve in 2 to 5 days. And the reason we use this bradykinin antagonist and a kallikrein inhibitor, like to remember again, icatibant and eclanatide, is to prevent airway involvement. So we saw that this hereditary angioedema is caused by increased bradykinin. Another place where you can study, see increased bradykinin is ACE inhibitors, and also they can present with same type of symptoms. So hereditary angioedema is done. The next one I want to go for anaphylaxis, but I'll come to that later. I'll finish all the conditions first. The systemic loop. Oh yeah, one thing specific about this hereditary angioma is we need always to differentiate between anaphylaxis and hereditary angioedema. So here you don't have the pruritus and urticaria or urticaria. Next, I'm revising systemic lupus erythematosus. Of course, the one thing with butterfly rash, systemic erythematosus, lupus erythematosus is what I always remember. I can never forget that. Butterfly rash, systemic lupus erythematosus. And top of that, they also have flu-like symptoms like fever, fatigue, weight loss, and symmetric migratory arthritis. Symmetric migratory arthritis, butterfly rash, flu-like symptoms, symmetric migratory arthritis, and there is also serositis. Serositis like pericarditis, peritonsillitis, and pleurisy. I have written here that they also have thromboembolic events, and that is due to vasculitis and anti-phospholipid antibodies. This thing I'll surely forget. So systemic lupus erythematosus people will have thromboembolic events as well due to vasculitis and anti-phospholipid antibodies. They have cognitive dysfunction and seizures as well. SLE, cognitive dysfunction, seizures. So in SLE, butterfly rash, flu-like symptoms, serositis like peritonsillitis, pericarditis, thromboembolic events due to vasculitis and anti-phospholipid antibodies. And what was the final thing I said? Cognitive dysfunction and seizures. This is something I need to remember. Seizures. Maybe the butterfly taps so fast and causes seizure in the mind. I don't know, because I'm not able to connect this SLE with cognitive dysfunction and seizures. And the lab will have hemolytic anemia, low platelets, and low leukocytes. Oh, now it explains the thromboembolic events to be. The lab presentation will have hemolytic anemia, low platelets, and low leukocytes, and hypocomplementementia, C3 and C4, C3 and C4, C3 and C4. Hypocomplementemia, C3 and C4. Another place where all the CD and C4 numbers are confusing me. All right, and the antibodies is anti-nuclear antibody. Okay, the test for SLE, is the specific test is anti-nuclear. The most sensitive test is anti-nuclear antibody test. This is something I studied long back. I feel ashamed that I don't remember this. The sensitive test is anti-nuclear antibody, and the most specific test is anti-DNS DNA and anti-Smith. Sensitive is anti-nuclear antibody, and the specific is anti-nuclear dsDNA and anti-Smith. Okay, and with the features, I have also added later that they have proteinuria and elevated creatinine. I think I have to remember all the clinical features of this SLE. And I have also added new murmur in a question. I studied the new murmur was the key point to figure out it was SLE and differentiate between other conditions. The new murmur, new hypertension, lymphadenopathy, splenomegaly. There are so many things of clinical features with this, and maybe I just connected butterfly rash, systemic lupus erythematosus. So I need to remember all this other clinical features as well. And there is multi-system involvement like arthralgia, pancytopenia, splenomegaly. So systemic lupus erythematosus is done, but I think I need to come back to it and revise again. The next condition I'm gonna go for is infectious mononucleosis. Infection mononucleosis is okay. So the features of infectious mononucleosis is fever, rash, and lymphadenopathy. Fever, rash, lymphadenopathy. sounds like very vague symptoms, with pharyngitis and lymphocytosis. This is also very vague. I don't know. I'm going to remember this. Fever, rash and lymphadenopathy, pharyngitis and lymphocytosis. So interesting thing here to note with infectious mononucleosis is that it is also caused by amoxicillin and other antibiotics. Pharyngitis, abdominal pain, rash, splenomegaly. So mostly if the question has amoxicillin and then they have this flu-like symptoms first resolved and then they have this flu-like symptoms, then think about this infectious mononucleosis maybe. And this is done. Yeah, I'll come back to anaphylaxis later. So next one is the small guys. I don't know. With other conditions, there were a lot of information to remember and connect one with each other to remember them. But these small guys are Chediak-Higashi syndrome. Chediak-Higashi syndrome. So if the patient has oculocutaneous albinism, recurrent infection, neuroabnormalities. Oculocutaneous albinism, recurrent infection, and neuroabnormalities. Neuroabnormalities is Chediak-Higashi syndrome. It's a lysosomal trafficking disorder. As there were not many questions about this condition, I just made a few notes. Hypopigmentation and neutropenia. So we saw leukocytosis in this guy, infectious mononucleosis, and there was leukopenia in SLE, and Chediak-Higashi syndrome has neutropenia, that has leukopenia. SLE had leukopenia. Chediak-Higashi syndrome has hypopigmentation and neutropenia. It's a lysosomal trafficking disorder, oculomotor albinism, recurrent infection, neuroabnormalities. And there is this common primary immunodeficiency things, which is like many things. This is also in 4 to 6 months. This happens in 4 to 6 months, just when the maternal IgG is waning. And if it is a B-cell immunodeficiency, there is cyanopulmonary infections, acute otitis media, pneumonia by encapsulated bacteria, T-cell deficiency, severe bacterial, viral and fungal. And if the patient has pneumocystis jirovecii pneumonia, it's mostly primary immunodeficiency. Pneumocystis jirovecii, it's mostly primary immunodeficiency. There can be ataxia telangiectasia as well, which is ataxia telangiectasia is a collection of dilated blood vessels in the eyes. So collection of blood vessels in the eyes, pneumocyte. Yeah, there was a question where the kid had telangiectasia and this pneumocystis jirovecii pneumonia. And there are small lymphoid tissues, and there are a few other conditions where I studied absent lymphoid tissues, which was X-linked A gamma globulinemia. So the primary immunodeficiency is something they are putting it all together, but X-linked A gamma globulinemia also has small or absent lymphoid tissues like tonsils and adenoids, And also one another thing I want to say is if the patient has fungal infection, mostly think about the disorders with T-cell deficiency, right? Because of the cellular immunity and those things. So key and yeah, the most common cause for primary immunodeficiency is this guy, pneumocystis jirovecii, and I'm saying it multiple times, so I'll remember it completely. And then I have a tabular column of all these primary immunodeficiency disorders. The B-cell disorders. What are the B-cell disorders? X-linked gamma globulinemia and common variable immunodeficiency, and both are mostly caused by encapsulated bacteria, and both are presented within less than 4 to 6 months. And in these people you find low IgGs and they have poor vaccine response. And I saw the live attenuated vaccines are not to be given to people with I think it's X gamma globulinemia. Of course, yeah. Sorry, it's severe combined immunodeficiency. They have poor live attenuated vaccines are contraindicated in severe combined immunodeficiency. Severe combined immunodeficiency. Gene defect is due to adenosine deaminase deficiency. All right, and where else I talked about the vaccine? Leukocyte aberration disease, maybe. No, I forgot. Maybe I'll see it in this tabular column. Sorry. So the B-cell disorders are X-linked gamma globulinemia and common variable immunodeficiency. It's usually present within 4 to 6 months, just when the IgGs are waning, encapsulated bacteria, and these also have enterovirus, low IgG, and low vaccine response. And the next one is combined B-cell and T-cell disorders. These present after 4 to 6. Sorry, I got it wrong. The B-cell disorders present after 4 to 6 months, because till 4 months they have the cover of their mother's IgGs, but the T-cell disorders present after less than 4 to 6 months. Sorry, less than 4 to 6 months. The conditions in T-cell combined deficiency are SCID, DGOT syndrome, Wiskott-Aldrich syndrome, and ataxia telangiectasia. But I forgot what I studied about Wiskott-Aldrich syndrome. Yeah, the bleeding after circumcision, umbilical bleeding, and a few other things. It's an X-linked disorder. Thrombocytopenia is what I forgot. Thrombocytopenia, low to normal IgG and IgM, and elevated IgA and IgE. I don't know how I'm gonna remember this, in all honesty. Let's see. And then, okay, so the key features here are viral, bacterial, and fungal infection, Candida pneumocystis. These people have failure to thrive because this happens much earlier in the life, so maybe I'll remember like that. And the lab findings are low leukocytes, of course, because of T cells and B cells, and low IgG, and they have poor vaccine response as well. Okay, and the phagocyte disorders are the two things we studied: chronic granulomatous disease and leukocyte adhesion disease. This presents in early childhood. The clinical features are skin and soft tissue infection, fungal infection, and catalase positive organisms. Encapsulated bacteria are in X gamma globulinemia and common variable immunodeficiency. And the lab findings are normal IgG, because these are not caused by the immunoglobulins. The thing is impaired oxidative bust, which is for chronic granulomatous disease. Leukocyte adhesion disease, integrins, chemotaxis. Okay. And the complement disorder is the fourth type of primary immunodeficiency disorder. It can present anytime. And the conditions, examples are C1q deficiency, Terminal complement deficiency C5 to C9. The lab findings are low CH50. So the complement test checks if all C1 to C19 are present. If it is not, that's the complement test. And they have normal leukocytes and IgG. They have normal leukocyte and IgG because of course these are complement disorders. C1q deficiency, terminal complement deficiency, C1q deficiency, terminal complement deficiency. Okay, and the lab findings I just told, the features or Neisseria infections and autoimmune diseases. So if there is a clue of Neisseria infection, then think about the complement disorders is what I have noted down mostly. So this tabular column and the comparison of primary immunodeficiency is done. This infectious, whenever I look at this infectious mononucleosis guy, I don't remember anything about them. Yes, I told you, I was telling it is very vague symptoms. And the next one is, okay, so as I was saying, the terminal component deficiency, you see a clue of Neisseria infection, then think about terminal component deficiency. Viscat-Aldrich syndrome I already revised. And hyper IgM syndrome, yeah, this is one important way. You have CD40 ligand deficiency, hyper IgM syndrome. CD40 ligand deficiency, hyper IgM syndrome. CD40 ligand deficiency, IgM syndrome. There are recurrent sinopulmonary infections. As the name suggests, there is increased IgM, low IgG and IgA. And one interesting condition here is the transient hypogammaglobulinemia of infancy, because it is not harmful at all. It resolves on its own. Just when the patient, just when the kid is waning off from the maternal IgGs, it's the time they start to have this, produce their own immunoglobulins. And the common presentation is rashes, eczema in infancy. Sometimes low IgM and IgA. So if there is, if the question has skin rashes and skin rashes and eczema during infancy, and there are low IgM and IgA, don't worry about it. There are recurrent infections as well, of course, due to the immunoglobulins. And after the hyper IgM syndrome, I have selective IgA deficiency. Selective IgA deficiency. So what does the selective IgA deficiency is that it is, I mean, with all the immunoglobulin diseases, there is recurrent infection of respiratory and GI. They have rashes as well. These IgA guys have rashes as well. One super important thing to remember about this selective IgA deficiency is that they cannot have transfusions, normal blood transfusions, because they will have anaphylaxis. They should receive only blood from IgA deficient people, or the serum completely washed off. Sorry, the plasma completely washed. I don't know if I'm saying this right, but yeah, there should not be any residual plasma in their blood. The blood product should be washed completely of residual plasma. And these people need to have a bracelet saying that they have IgA deficiency, selective IgA deficiency. The question I think I studied was, there was an accident and the O negative blood was given and she started having an anaphylaxis. So what could be the reason? Was that selective IgA deficiency. And another small condition is cystic fibrosis. In cystic fibrosis, you have impaired airway clearance. The impaired airway clearance predisposes to cephalic pneumonia. B cephalic. What was that? B? Burkholderia, which is something I couldn't pronounce. Burkholderia pneumonia. There are recurrent pneumonia, sinusitis, and the investigation of source is sweat chloride test. These are also very few important information. I don't know how I am going to remember. Sweat chloride test, cystic fibrosis, impaired airway obstruction, B cephalic. B is the portion which I can't pronounce. And okay, as I was telling earlier with the skin rash, edema, about infectious mononucleosis kind of presentation. Infectious mononucleosis kind of presentation is sometimes it is caused by AC inhibitor as well. So if a patient is there is a patient of CAD and they are taking an AC inhibitor and they present with this rashes and other stuffs, rashes and what are the stuffs? Fever and lymphadenopathy. Oh my god, this is so vague. Fever, rash and lymphadenopathy, then it could be due to the AC inhibitor they are taking. So for the management, check if there is airway compromise and vasomotor instability. If there is airway compromise, then we give them a subcutaneous epinephrine, and if it fails, ET intubation. Check for airway compromise, ET epinephrine, ET intubation. And just that we are studying about AC inhibitors, all these things we know about AC inhibitor side effects or cough, hypokalemia, precipitate renal failure in patients with renal artery stenosis, hyperkalemia. Other CAD drugs and side effects which I studied from the other options, I'll just go quickly over here. Is nitrates causes headaches, hypotension, develops eventually. And beta blockers, low heart rate, AV block, bronchoconstriction, significant in asthma and COPD. And this is the most common question I studied for my beta blockers are contraindicated in patients with asthma and COPD because of the bronchoconstriction. And of course, beta blocker will reduce the heart rate, AV block. And this is something, sexual dysfunction. Beta blockers also cause sexual dysfunction. There are no much side effects with clopidogrel. Statins causes hepatotoxicity and myopathy. Okay. And the next thing I'm gonna revise is serum sickness and serum sickness-like reaction. So the trigger for serum sickness is foreign proteins in antivenom, antitoxin, and monoclonal antibodies. However, for serum-like sickness reaction, it is mainly due to medicines, particularly the antibiotics, Cefalar, penicillin, trimethoprim, the CSMX, sulfamethoxazole. I need some water. Yeah. So the serum sickness, there is a high titer in reaction, there is minimal or none. Onset 5 to 14 days, 5 to 14 days for both. So this is where we will get confused. Fever high and fever is low in serum sickness like reaction. Arthralgia, both of them have arthralgia. Urticaria, both of them have urticaria. Resolution, both spontaneous, and if it doesn't resolve with the serum sickness like reaction, and so just stop the drug, right? And the next one is infection after liver transplant. So the chronology is, if the infection is within 1 month, it is bacterial cause from operative complications. Less than 1 month is bacterial. 1 to 6 months is opportunistic infection, opportunistic pathogens, and greater than 6 months immunosuppressants at maintenance level, and it is community occurred. And there were some opportunistic pathogens. Most common I noted down here was cytomegalovirus, Aspergillus, Mycobacterium tuberculosis. So Mycobacterium tuberculosis we will surely remember. Aspergillus, yeah, cytomegalovirus. And also I studied about calcineurin inhibitors in a question because there was a patient after a renal transplant, I believe. So the calcineurin inhibitors I studied were tacrolimus and cyclosporin. Inhibits interleukin 2. So there is inhibits interleukin 2, which affects the T lymphocytes, and there is chronic immunosuppression, which was actually intended. But the adverse effects are nephrotoxicity, increased hyperkalemia, increased potassium, increased BP. They have neurotoxicity as well. Tremor, which is most common. Visual disturbance and seizures are least common. Glucose intolerance. Tacrolimus has higher effect about this glucose intolerance than mycophenolate and mycophenolate mofetil and mycophenolate sodium. So what is most common with this mycophenolate mofetil and mycophenolate sodium is gingival hypertrophy, hirsutism, and comically alopecia and GI disturbances. And why I studied this question was there was a renal transplant guy who had glucose. His glucose was not in control even after insulins, and he had tremors on both his hands. So these were the key features of the question to arrive at a decision that it could be due to tacrolimus, and there were some other drugs which were given in the option. And the next is humoral immunodeficiency syndrome. I have made a tabular column of B cell count, B cell count, IgG, IgA, IgM, IgE, but I'm not gonna read this now because I don't know, even if I read this out loud, that doesn't make any difference. CD40 ligand deficiency, hyper IgM, that's something I forgot. CD40 ligand deficiency. CD40 ligand deficiency is hyper IgM. Hyper IgE. Oh yeah, hyper IgE syndrome is also called Job syndrome. This is something you will know, you can remember. And yeah, I left anaphylaxis for the final. Oh, every time I look at this infectious mononucleosis, I'm getting scared. I don't know why. Even though it has maybe it has vague details, and there will be one whole ass question and the answer is wrong. I don't know, man. Okay, anaphylaxis is something easy. IM epinephrine, we can give a maximum of 3 doses. IV epinephrine in severe cases. And type 1 hypersensitivity, we give it in type 1 hypersensitivity. It is IgG mediated, and there are 2 types, biphasic and protracted. Biphasic symptom recurs in hours after resolution, but in protracted symptom lasts hours to days. And type 2, there are no spelling, is something I've written down. Type 4, yeah, tuberculin test, contact dermatitis, local skin test, type 4, right? And type 3 is this serum sickness, type 3. Oh, this is also something I'll never forget because it was one-liner thing, like SLE butterfly rash. Type 3 serum sickness. And type 1 this is also something basic, which is type 1 hypersensitivity is caused by mast cell and basophil degranulation. It is caused by mast cell and basophil degranulation. Mast cell we will know, but this basophil degranulation, that will pass. Okay, in anaphylaxis, IV crystalloid and Trendelenburg positions are advised for low BP. Albuterol for bronchospasm, early intubation for upper airway obstruction, and anaphylaxis criteria, which I just need to go once. So the rapid onset of one of these, so to diagnose it as an anaphylaxis, we need to have one of these 3: skin mucosa involvement and either BP or respiratory distress. So this is the first point. Out of these 3, skin mucosa involvement, low BP, and respiratory distress. And this second point is more than 2 organ systems should be involved: skin mucosa, respiratory, CV, high BP, high heart rate, syncope, GI, abdominal pain, vomiting, and diarrhea. And the third one is hypotension after exposure to known allergen. So the first point itself has a separate criteria, and the second and third, out of these 3, if we have just one, then it confirms anaphylaxis. And there I go. I have kind of finished everything in within an hour. I'm feeling so happy about it. And there are a few one-liner things I have noted down from what I studied. Maybe when I study those systems, this will come in detail and I'll remember them better, but I just want to read them out loud for my sake when I revise later. So giant bilobed nucleus is seen in Hodgkin lymphoma. Giant bilobed nucleus, Hodgkin lymphoma. Increased peripheral myeloblast, acute myeloid leukemia. This is where they were doing the ice bucket test, right? Increased peripheral myeloblast. Low CD4 counts, HIV infection, isolated T cell defects, giant granules within neutrophils is in Chediak-Higashi syndrome. Giant granules within neutrophils, Chediak-Higashi syndrome. Now this makes me want to go back and revise. It's a lysosomal trafficking disorder. What do you see in this? In the neutrophils? Giant granules in neutrophils. Maybe I'll write that down here as well. Giant granule within neutrophils, hypopigmentation, neutrophils, and this hypopigmentation also brings me to this ocular albinism, which is the same thing. See how I forgot. Lysosomal hypopigmentation, ocular. Giant granules within neutrophils. Giant granules within neutrophils. And this amoxicillin can cause this pharyngitis, abdominal pain, rash. I studied already. And also patients with EBV infection, the infectious mononucleosis, we should be very conscious about the antibiotics as we studied earlier. And to diagnose asthma, what do we do? Methaqualone challenge. And another very random fact I have noted down is atopic dermatitis has increased IgE and erythematous plaques. Increased IgE and erythematous plaques. Atopic dermatitis. Yeah, I think IgE, right? Type 2 hypersensitivity. Sorry, type 1. Type 1 IgE mediated atopic dermatitis. How easy that? And the final random thing I have noted is about this anti-thrombocyte globulin. It is derived from rabbit serum. Anti-thrombocyte globulin is derived from serum rabbit, and the target is human T cells. It is a very potent immunosuppressor. And the adverse effect here is serum sickness. Which is a type 3 hypersensitivity derived from rabbit serum. Targets human T cells. I told the name wrong. It is anti-thymocyte globulin. It is not anti-thrombocyte. It's anti-thymocyte globulin derived from serum rabbit immunoglobulin. And that's all I studied for past couple of days in immunology, and I'm planning to study a bit of cardio later this day, and I'll be meeting my study group to study some respiratory tomorrow. I hope I could do these videos continuously so I can have them to revise later. Thank you. I hope we all pass the exam.